Good evening, everyone, and welcome to episode 9 of the Pain Consultants USA podcast. Tonight, Dr. Bonner and I are going to be talking about shoulder pain. Um, and we're going to hopefully have a little different format. I'm going to present a case, and that'll kind of lead our discussion. Dr. Bonner will kind of tell us how he approaches or would approach this patient if he walked into his office. So, hopefully we can highlight our thought process when evaluating people with shoulder pain. Could touch on some physical exam maneuvers, and then we'll get into diagnosis and treatment of such injuries. So before we get started, how are you today, Dr. Bonner?
Doing well, thank you. How are you?
Not too bad, not too bad.
Okay.
So uh, okay, so let's jump into the case. So we have a 35-year-old male patient uh, comes to your office with about a 6 to 9 month history of shoulder pain. It really kind of bothers him on both sides, worse on the right. He is right hand dominant. Um, he says the pain kind of started after he became more physically active. Started to exercise, lift weights, and even was doing some martial arts training. Uh, Pain seems to be worse with those activities, especially overhead. Anytime he lifts his arm overhead, and then any type of pressing movement. So if he's doing push-ups or bench press, um, when he lifts his arm overhead, pain's kind of in the front and outer aspect of the shoulder. When he lifts, or when he does pressing movements, more kind of on the side and the back part of the shoulder.
hmm
Um, Overall, it pretty much stays in the shoulder, doesn't radiate down the arm, doesn't really have much neck pain. When pain's really flared up, laying on that shoulder might aggravate it. He will take some anti-inflammatories and ice, and it usually helps. But if he the next day or when he gets back into those activities, he kind of flares it back up. He does note that when he does some pressing movements like bench press or for chest or push-ups, once he starts doing it more, so he might get through the first set of 10 reps, the second set seems a little easier.
hmm
Um, other than that, he's got no real past medical history. He's healthy guy working, just trying to better himself with some exercise, but the shoulder pain's really interfering with things. So, okay, so this patient walks into your office. How do you know, what's your approach?
Yeah, I think that's a pretty, good history. I guess maybe I would just have them kind of point out kind of exactly where it hurts. I think you said sometimes in the back of the shoulder, sometimes more in the top, did you say sometimes?
Yeah, so with when he does any overhead arm activities, it's
hmm
more kind of in the front and off on the side.
hmm
When he does any type of pressing movement, it's on the side and more in like the back of the shoulder a little bit.
Yeah. Um, so, after we get a good history, we always kind of go into a physical exam. So, um, you know what are things that we look at there. So you always want to kind of you always you prefer to see the shoulder kind of without any clothes covering it. So I want to compare the one shoulder to the other shoulder. How do they look? Is one higher than the other? Is there some kind of wasting of the muscles? I'm always looking for that around the shoulder. And kind of just any bony abnormality or anything. We don't have any specific trauma here, so I'm not really thinking any fracture or any like dislocation of any of the joints or anything. But he is doing, I think you said, martial arts or jujitsu, so
Oh,
perhaps someone is kind of pulling on his shoulder here and there and kind of uh, may have kind of caused a traumatic injury. So you just want to look at things kind of without any clothing covering it, just to see what everything looks like and make sure it's relatively symmetric. Not everyone is completely symmetric, but the first thing I do is just kind of take a look. I like to, think of inspecting the shoulder and just look around and see what it looks like from the front, from the side, and then from the back. Um, So, on the back, we're always looking at the shoulder blade, which is the scapula, and you can see a lot of asymmetry with that sometimes. So you always want to check on those things. Usually, after looking at the shoulder, I'll then start kind of feeling around a little bit from the shoulder. So I usually start away from where it hurts and then kind of work my way towards where it hurts. That's kind of something that I've just adopted myself. Um, and with the shoulder, I start, for those who don't know, the shoulder is extremely complicated. So although the shoulder joint is here, or let me point to this shoulder, it's here, the shoulder connects all the way up to your neck and really all the way down the side of the arm bone here, the humerus. Um, so I start kind of over in the chest area, palpating what's called the sternoclavicular joint, work my way over the clavicle, which most people have heard of. It's a bone here that connects from the chest over to the shoulder joint. And then I work my way out there. That connects to the scapula at the AC joint, which can sometimes be painful. So I work my way through there, see if that's a tender area. Work my way along the musculature up here and into the neck. We see a lot of people that get pain up in there, but they'd probably be coming in more complaining about neck pain. Then I work my way around the front of the shoulder joint. Okay, so there's different bony prominences here, and the biceps tendon is here in the front. Work your way around the side. Most commonly kind of tender out in this area if you have a subacromial bursitis or impingement syndrome, which some people might have heard of. And then also to the back of the joint, some of the other muscles are back there, and you can kind of palpate the joint line, the glenohumeral joint line, which is the main shoulder joint posteriorly. So I like to work my way around like that and just try to really narrow down if there's one specific area of tenderness there. So that's how I'd start. I don't know what you think about that, what you think, and how you start with that. I don't know.
Yeah, I think to a degree, the location of pain, just based on even palpation or where the patient points to, can kind of clue us in a little bit. When we're talking about like joint pain itself, we do know even like a bursitis type pain, which we'll talk about, it can refer a little bit either down the arm or into
Yeah.
a different area. So, but I definitely agree with you. You have to inspect. You have to look at the area. Ideally with either a tank top or a cutoff shirt or in a male topless to really look at the shoulder, look at the muscles, and then what I'm sure you're going to talk about next, kind of the range of motion. You have to visualize the shoulder and the scapula. We don't really talk, so you don't think about the scapula as much, but the scapula is, that is the shoulder, and
Yeah.
that kind of directs everything.
Yeah. So, um, what when you mention this guy's story, what I tend to think about right off the bat is some type of kind of like instability or micro instability of the joint. Somebody who wasn't previously active or athletic and exercising, getting into new exercise program and maybe kind of building too much strength, like overall strength around the joint without honing in kind of the stability and the control of the joint. And I think that's where, like you said, next would be kind of what's the range of motion. So, passive range of motion, meaning, I grab the arm and I move the arm and inspect how well it moves. And well, the patient doesn't do anything active. And then you also have the patient do everything actively. So lifting the arm straight up in front of them, lifting it out to the side, lifting out to the side and rotating it in different directions, and then also kind of reaching behind them or trying to scratch their back and kind of help assess the range of motion as well. And so you want to do that without them kind of doing anything, and then also see if they are able to do it actively and kind of inspect that range of motion there. And then throughout that range of motion, one, is there any limitation? Two, is there any pain or any symptoms related to doing that? And that may clue you in on what some of the problem is there. So definitely a big part of the examination, and along with that, some of the special tests that we do in the shoulder for impingement or kind of a bursitis, some of those can be done right along with the range of motion test because they're somewhat very similar. You're kind of lifting the arm straight up in front of the patient and kind of internally rotating it, or you're holding the arm out and internally rotating it a different way. So kind of mix those in to see if there's any pain with those problems.
Yeah, I mean, I think that's I think we have a similar background in training,
Yeah,
so I
yeah,
do a very similar joint and musculoskeletal exam from that standpoint.
yeah,
Um, it's hard over this kind of format to really show all these different exam maneuvers. So, I know we've talked about one of our goals would be to kind of just create a video with examination of the shoulder and self-exam maneuvers. So, and to be able to describe in a little more detail, how those things are done. So tonight, just bear with us when we talk about these different special exam maneuvers. That all these tests have names, usually based on whoever created them. But you can look them up. They're very common. They're easy to see online. But we'll hopefully be able to go into more detail with that at a later date in a little different format.
yeah. And I guess, like you said, with the active range of motion, a lot of times we want to make sure we look closely at the scapula from behind. We want to see how that's moving compared to the other scapula, because a lot of times there can be some issues there. Um, if anyone's listening and watches NBA basketball, I think the scapula came into a lot of people's lives when if they're Philadelphia Sixers fans like I am. Markelle Fultz, who was their number one draft pick a couple of years ago, he had a shoulder problem and couldn't shoot appropriately. And the first diagnosis that they came out and said was, he has a scapular dyskinesis. And so that's probably the first time a lot of people had heard about that, but it's a common problem that we see. Um, and the way to notice that really is a lot with the range of motion testing with the patient. So I think Markelle Fultz then got a different diagnosis later on, but that's initially what they were working on with him was his scapular motion. So you may have heard of that if you follow along the NBA, or you can go back and read about it. Um,
Yeah, and the specific, like with the range of motion that you're describing, how we do that is we stand behind a patient. Again, the scapula and the back part of the shoulders are exposed. I'll have them just raise both arms up at their side, try to bring them overhead. Do that repeated or repetitively, not too fast, and then I'll have them bring their arms up in front of them and overhead like that. Do that a few times, and if the scapula, which can you see my hands here, Doc?
yeah,
Right. So if you're looking one on each side from the back, when you bring your arms out, they should kind of move in this direction together. Sometimes we'll see one they'll move out and then one will kind of drop down real quick while the other one's nice and smooth. It's almost like a dumping type phenomena, they call it, or one might kind of rotate like this. So we're able to kind of be clued in with regards to what muscles might be weak, because there's a bunch of muscles that attach to the scapula. And if there's certain ones that are weak, then the scapula's motion's off. That puts different abnormal stress on the shoulder joint, which we'll talk about. And like the old song, everything's connected. And then,
yeah,
then we start to experience pain.
yeah. So the next thing I usually test out would be strength around the joint. Um, you know, with someone like this without like a specific traumatic injury, I'm not usually expecting to see too much in terms of a deficit, but you can tear your rotator cuff with kind of smaller level traumas or, falling onto an outstretched hand or something like that. So, but you want to test all the strength around the shoulder. So that involves lifting the arm up to the front, to the side, posteriorly to behind the patient, rotating the arm different directions and things like that. So we want to get a good idea of, is there any deficits of strength, and that can clue into any kind of tendon injury or muscle injury or something of that sort. So always want to get a good strength examination around the joint. If there's any radiation of the pain anywhere else, which we're not really talking about here, but you always want to get a good exam of the entire extremity. and make sure that there's no deficits anywhere else in the extremity, because sometimes you can have shoulder pain related to a problem in the neck. And so if you get a pinched nerve in your neck, we want to check out the whole arm and make sure that really everything's okay there.
Yeah, and maybe this is a good spot to just take a step back and describe in just a little bit of detail. And I know it's hard just by listening to us. It'd be easier with visual formats, but like the shoulder joint, like the joint itself, the rotator cuff, and what it is, right? So, we think of the hip kind of attaches to the pelvis. We call it a ball and socket joint. So really the femur, which is what the hip, and then it kind of attaches to the pelvis with the acetabulum, right? So that's a ball and socket. It's in there pretty good. The hip joint or the shoulder joint is similar, but there's not as much coverage. There's very little coverage, right? So your upper arm is attached to your body just with muscles, ligaments, tendons, to the scapula. The scapula is your wing bone in the back, and that is attached to your body just with muscles, right? So there's no true like bony attachment there. So we really rely on all these muscles and ligaments and stabilizing structures to do just that. So the rotator cuff, when you hear that term, it's made up of 4 muscles. And their job is to keep the shoulder in the correct place and to allow you to kind of move your arm through space, overhead, out to the side, without difficulty. So I think that's important, and that depending on the types of motion and where you might be weak, that clues us into which muscle of the rotator cuff there might be an issue with. So that's important too.
I think we talk about stability when it comes to a lot of the different joints that we treat when they're painful, and I think that's such an important point for the shoulder. If the rotator cuff is not working appropriately, the rotator cuff is the main kind of stabilizing function of the shoulder, and if you don't have that, the shoulder joint is not stable, and you're prone to have pain. And so that can't be stressed enough how important that is to have that stability. I like to talk to patients about the fact that, like you just said, you have a good ball and socket for the hip joint, where the hip kind of fits right into the socket, and it kind of covers completely. But with the shoulder, it's much less of a socket, and so really the arm is just kind of hanging off the body, and it's held there, like you said, by the muscles and other tissues. So if you do something to aggravate the joint, not only is maybe the joint capsule aggravated, but then all the muscles around the joint are constantly spasming because they're trying to stabilize the joint, and they're trying to hold it in place so that it's not more irritated. And so a lot of times, I try to encourage patients to give the shoulder rest by either sitting and supporting it with a pillow under the shoulder, or putting it in a sling temporarily, not all day every day, but for a few hours a day, to give the muscles around the joint rest, because if they're spasming, they're clearly telling you something about what's going on with the joint. And so and they don't get any rest unless you lay down and support your shoulder, or you sit down and support it, or you put it in a sling so that the muscles can rest. And sometimes they may need that if you've injured it or it's painful for some reason.
Yeah. So I guess we should just name the rotator cuff muscles real quick and kind of say what they do. So, right, your supraspinatus muscle is the one that will raise your arm out up to the side along with your deltoid. Your subscapularis, which kind of attaches to the front of your shoulder, kind of next to the biceps tendon, will help with what we call internal rotation, so turning your arm kind of in. It's hard to show in there, but then you have 2 tendons on the backside of the shoulder, the infraspinatus and teres minor, which help with what we call external rotation, or turning your elbow out, kind of like that motion. So again, we'll look for that on examination. The biceps is not part of the rotator cuff, but one of the long head of the biceps, right? So that actually comes up, attaches onto the glenoid, and part of like the labrum kind of meshes in there, and that is what connects to the humerus and helps or creates the shoulder joints. So the biceps tendon also can be under a lot of stress when other parts of the rotator cuff are not working appropriately.
Right. Right. All right, so what's next on the exam? I think, like you just mentioned the biceps tendon, so there's certain tests that can be done for that. One with kind of holding the arm out straight and applying upward force to the examiner to see if that causes pain. Another one, the bicep is used to it can flex the shoulder, meaning lift the arm straight up. It can be used to flex the elbow, but it's not the main flexor of the elbow. And it can be also used to kind of supinate the forearm, meaning turn the palm up. And so there's another test that we do where we have you supinate the forearm and see if that causes pain in the shoulder. Additionally, the biceps tendon, like you said, is right in the front, so kind of palpating right in the front there can be very painful for people with biceps tendon issues. And those are kind of the main tests that I go to for a biceps tendon issue if I think that's going on.
Yeah, I mean, I think that's a very good description there.
And if you've torn the biceps tendon, then you can get kind of a bulging muscle in your arm. So it may look like you get a really big bulge. I'm going to try to get it in the picture here, kind of down here. If the tendon tears, the muscle retracts down, and then you can get a bulging muscle kind of showing up, and you might say it looks like you have like a big ball in your arm there. So that's not very common, but you may see that.
Yeah, the old Popeye sign there.
Yeah, exactly. Um, all right.
Okay, so obviously we didn't really examine this patient, but if we examine them and based on the history, we found that there was a lot of pain when he was doing overhead. Anytime we brought the arm overhead, we may have did some testing for impingement syndrome, which we'll talk about, but kind of rotating the arm in with the arm, what we call abducted or lifted up out at its side at the shoulder height. That reproduced some pain. We did some testing for labral issues and, kind of brought on some pain. And strength was normal, sensation in the arm was normal. So kind of what would you do next?
So, I've had a couple patients like this that um, what I've thought generally is there's some kind of small amount of instability going on. And I think, like I mentioned before, there's maybe too much strength in the large muscles that's overcoming the stabilizing muscles. And so it's kind of destabilizing. And so, you can imagine if you're doing a large bench press that takes a lot of shoulder stability. And if you don't have the stability, then that humerus can kind of slide out of position in the glenohumeral joint, the main shoulder joint. And so, what you're describing, different types of pain in slightly different areas related to different activities, I would say that he's probably got some deficit in rotator cuff strength, maybe in comparison to the strength of the larger muscles. And so my initial approach, as long as I didn't see anything major on examination, would kind of be to advise on a scaling back of the exercise program in terms of number one, bring whatever exercises are causing pain, bring them way down. Okay, so maybe he started way too high on a bench press. Like, just because you can bench press 200 pounds doesn't mean you should be bench pressing 200 pounds. So let's bring that weight way down to a level where we feel no pain, and let's focus on slow, controlled reps and sets. Okay, so we want to make sure that we're controlling the movement very well and we're using all the muscles to stabilize the joint. And then additionally, we want to train up the muscles that stabilize the joint. And to me, that would be with good rotator cuff strengthening exercises. So doing those motions that we talked about that are used by or done by the rotator cuff, like internal rotation, external rotation, and abduction, lifting the arm up to the side, we want to train those muscles to be able to control the joint better. And then um, when we get a pain-free, level of bench press, and we get some training with those exercises, then we slowly increase back to the level where we were before, and see if we can get up there kind of pain-free as opposed to how we were before. The martial arts aspect of it, I would really just, I'm not, I don't know jujitsu too well. I know they do a lot of holds and kind of like arm bars and things like that. So, I'd really encourage him to try to avoid getting stuck in any really compromising position for that shoulder. If there is a little instability, we don't want to create more instability. And if someone puts you in an arm bar and is yanking on your shoulder, that could be really bad for kind of the long-term health of your shoulder. So, I would just kind of encourage staying away from that as much as possible. But I had a good friend who came to me with a very similar problem where he's an athletic guy who lifts lots of weights, and he was pushing his bench press up in like the 250 to 300 pound range, and he was finding he was getting some shoulder pain, some posterior shoulder pain as he got up to the higher weights. And I asked him if he did any kind of like rotator cuff strengthening exercises at all as part of his program, and he was like, no, I don't really do anything like that. And I was like, I would tone down the bench press, do these exercises, and then slowly work it back up. And he said he never had a problem after that once he started doing those exercises. And the problem you're describing kind of sounds like a little bit of instability where maybe the shoulder is just stressed a little too much and it's not stable enough because it hasn't been trained up to be stable. So we need to train those little muscles just as much as we need to train the big muscles. So I don't know, that would be my starting point, especially if I didn't find anything really significant on exam that was really concerning. I don't think I would need to order any type of test to look for anything in particular. I think that we just kind of change the exercise program and we could probably find something that works for him.
Yeah, I would agree with that. The one thing I should have mentioned, on observation, or we should have mentioned was, like where your shoulders are, like forward rotated versus retracted. Um, so that's important too, because if a lot of us, right, we live with kind of everything's tight up front. The chest is tight, pulls the scapula and the shoulders forward. Um, and then it causes some abnormal movements of the scapula too. So we always look at that. I would agree what you said there. I always kind of start with rotator cuff stabilization, especially scapular stabilization exercises, which we'll get into. I agree, cut back right now on the offending activities. Sometimes it's just you have to give it a rest, and it's not so much you have to strengthen and get the muscles really big. You don't have to get the rotator cuff muscles to hypertrophy.
Absolutely.
But you just need them to be firing correctly.
Yeah, you need to engage them for sure.
Yeah, and that's where a good example of that is when an individual starts working out, you'll notice that you get stronger before the muscles get bigger or hypertrophy. And a lot of that is like the just muscle memory, like neuromuscular kind of facilitation, firing. So you're really just like coordinating the nerves, the signals going to the muscles, and the muscles to contract. You're just you're kind of waking them up. Right. And that's what you kind of have to do with a lot of these types of injuries around the shoulder.
Right.
The one.
I was just going to say that fits what you were describing with how the first set he gets some pain and then he can kind of work through it and then it gets better. So he's maybe all he needs to do is start with just a bench of the bar, start with a really low weight to kind of trigger the muscles to get working. And then once they're working, he's stabilizing the shoulder appropriately, and then he can work up to higher weights. So that's one of the important things about kind of warming up when you exercise is getting the muscles engaged before you're going to do whatever kind of strenuous exercise you're going to do, so you're not just triggering them all of a sudden and trying to push them to max capacity, because that's not a reasonable way to do things. You need to get the correct signals in your nervous system firing to get the muscles working appropriately. And that, I thought that was an interesting point that you mentioned, because it makes perfect sense that if he starts out, he has the pain, but then it eventually goes away, and that's probably because he's improving the stabilization as he goes.
Yeah, exactly. That's my thought as well. From that standpoint, I would agree with you. We maybe give it about 4 to 6 weeks with kind of this type of scale back and focus on rotator cuff and scapular stabilizer muscles. Um, and if at that point there's patients still having some discomfort, they're active, they're trying to get back to being physically active, and it's really interfering with their quality of life. At that point, I would consider at least I would entertain the idea of some imaging. Um, you know, Even though I'm hopeful it won't show anything, I'd start with an X-ray. People who bench press a lot can get an issue at the tip, or like that, what we call the distal end or of the clavicle, which is where it comes out and attaches to the acromion, which forms the AC joint. So you can get issues there in weightlifters. So an X-ray would help us with that. An X-ray could clue us in to possibly an issue at the shoulder joint or the labrum or the glenoid if there's a little bony involvement from like a traumatic injury, possibly during some of his martial arts, like forceful pulls down on the arm or things like that. And then just to make sure, no bad arthritis that we wouldn't expect in a younger individual. If you do have a large rotator cuff tears, you can see changes on the X-ray with regards to where kind of your humeral head sits. So if you can see here, right, so pretend this is the undersurface of your acromion, which is like the top of the shoulder. And then there's a space here. You alluded to it before, subacromial space. Then you have your humerus, which is the top of your arm there. And then every time you move, there should be enough space under there. When you have a rotator cuff tear, that bone kind of slides up, and then it's almost hitting the bone on top of it. Or some people, their acromion, just the way it's made, instead of being flat, could be curved or it could be hooked, and then it really kind of interferes with the ability there.
Yeah, definitely. Yeah, I would say, that X-ray can clue you in, and I see radiologists who even comment on the acromion sometimes and say, this type of acromion leads more to impingement syndrome, like we're talking about, which is one of the most common causes of shoulder pain for people. And why does that happen? Like you said, if you tear the rotator cuff, the humerus can certainly elevate. But if you don't have good control of the rotator cuff, you have dysfunction in the movement in the same way, and so the humerus can kind of bump into the acromion there and cause that same type of problem. It's of course more common if you kind of completely tear the rotator cuff, because you can't kind of pull the humerus, the arm bone down at all. But if your rotator cuff isn't working appropriately, you can get a similar type of issue there. So again, I would maybe expect to see a little bit of rotator cuff dysfunction in this patient. Maybe not working appropriately. Maybe the scapula is also not kind of working appropriately in conjunction with that rotator cuff. So.
Yeah, I guess one other thing we should mention on an X-ray that you can see, sometimes you could get buildup of calcium in the tendon themselves. So it's called a calcific tendonitis. Calcium will show up on an X-ray because bone is made of calcium, so it shows up as white. It could be we'll see these white areas within the tendon. So an area where we shouldn't see kind of bone formation or calcium deposits, we'll see them. So that can clue us in as well. So say he does, either goes to physical therapy or under your direct supervision, he does an appropriate rehab program, which again, hopefully in a different format or subsequent talks, we can kind of go into more detail about, well, how would we strengthen the rotator cuff? How would we work on range of motion? How would we stabilize the scapular muscles? But say he does all that, and he comes back and he's still not ready to return to activity, can't really progress with his therapy. I guess what's your next step? What would you consider?
Yeah, that would be kind of when I would tend to order some imaging to get a better picture of what's going on. I think for the shoulder, it can either be an ultrasound done by an experienced sonographer, or an MRI of the shoulder. Um, Sometimes if you're really expecting a labral issue, you might add some contrast into the joint for that MRI, but typically just a MRI without contrast or an ultrasound to get a better picture of the rotator cuff and some of the other soft tissue structures in the shoulder joint, and then see what that shows. That would be really my next approach, probably. See if there's anything glaring there.
Yeah, and I think just to highlight a little bit more on the different imaging modality choices, right? So, what an X-ray doesn't show is tendons, soft tissue. So that's why we need an MRI or an ultrasound, right? We're really looking for what the soft tissues look like. When you look at the studies comparing diagnostic musculoskeletal ultrasound, so this isn't ultrasound that, this is the type of ultrasound if you're a woman, you're pregnant, and they were checking the baby. So that type of ultrasound, they can do of the shoulder, different probes and all that, but you can get very fine detail with regards to the tendons and the structures around the shoulder, just as good, if not a little better, as an MRI without contrast. And then you alluded to the MR arthrogram where you're injecting contrast. Yeah, you need that to look inside the joint. That's the most sensitive. But again, that's very rare that we have to order that.
Yeah, it's not needed very often.
Yeah. I guess what would make me decide an MRI versus a shoulder ultrasound in a patient would be body habitus, right? Ultrasound is limited. So if you have a really big patient, whether it's, a lot of muscle or a lot of fat, could be difficult to get a great image with the ultrasound. So sometimes you might lean a little more towards MRI. Some of the benefits of ultrasound, claustrophobic patients don't have to worry about that. It's cheaper as well because doctors will do it right in their office. It's hard to see a musculoskeletal radiologist without a referral to go somewhere for this test, but there are a lot of physicians nowadays, usually PM&R based trained, so physical medicine and rehabilitation trained physicians who do this as part of their training, or if they went on to do a sports medicine fellowship, are usually pretty skilled with diagnostic ultrasound. And there's a whole criteria to be used for shoulder imaging. So ultrasound's cheaper, sometimes more readily available. The caveat is patient can't be too big. And it is user dependent, so you have to make sure you're with someone that's very skilled.
Yeah.
Okay, so I think this kind of brings us to a point where okay, let's say we don't see any tears, but so we diagnose them with like a bursitis or an impingement syndrome. Mm-hmm. So that's one avenue versus, rotator cuff pathology, or even labral issues. So let's first talk about, there's no tear. Seems like everything is inflamed due to the reasons we talked about. Hasn't responded to physical therapy. What would be your next step?
Yeah, usually.
He's been using NSAIDs and things like that. Sorry.
Yeah, if they haven't made any improvement at all, I tend to offer an injection into the subacromial space if that's what I was thinking. That's a pretty simple injection for patients who don't know. It's it's landmark guided. I can do it, probably with your eyes closed at this point, and so that's I would often try that as a first option for a patient. Most commonly done with steroid medication first, like a cortisone injection, to see if that would help. You can also obviously do that with other things like we've discussed before, like PRP. Um, but typically, I would offer a steroid injection into that subacromial space to see it. Number one, part of that injection is putting lidocaine in, and so when I inject that medication, then I can re-examine the patient and see if the pain goes away at all. And then maybe if it is coming from that space or that bursa, then I should have some relief of pain, some significant relief of pain right after the injection procedure. If I do the injection and I don't see any relief of pain with the same physical exam maneuvers after the injection, then I'm kind of questioning, okay, is it really coming from that space? Maybe it's not something in the subacromial space there that's causing the issue. Um, but that's typically what I'd start with. What do you think?
Yeah, I would agree. And just for our viewers, so this again, the subacromial space. So you have the humerus here and the acromion. So that's space in between. So what's in that space are the tendons, which run right over top of the bone. So then over top of the tendons and the bone, you have this space there, and there's a little bursa there that we can see on ultrasound, or the theoretical space where it is. And what you do, like Dr. Bonner's talking about, you just put steroid into that space over top of the tendon, so it kind of coats the over surface of the tendon. So if there was any impingement syndrome, which is when, again, the bone or the tendon might rub underneath or the undersurface of the acromion to kind of flare things up, uh, usually will help to calm things down.
Yeah.
We use this in conjunction with exercise then, right? So this happened for a reason, like we talked about. So once we calm it down, we don't recommend you just kind of go back to doing exactly what you were doing before. You use that to kind of break through new barriers and progress with your scapular stabilization techniques and your rotator cuff strengthening.
Right. And also for patients to know, like we mentioned, I think in the tennis elbow podcast, is that if there is a tendon issue, we definitely don't want to be putting that steroid directly into a tendon. There is concern that we could make it more likely to have a tear. So, I don't know how you feel, but a lot of times when I see someone, and sometimes I get a patient and they, have an acute tear and they've already had an MRI before they come to see me, and they come in, they're like, I want an injection. And I say, well, we got to hold on a minute because I'm not putting a steroid around that tendon when it's partially torn and it might tear even more. I think we got to wait a little while, maybe let it heal a little bit. It's on its own, and then see if you get better and go from there. What's your approach in that kind of situation?
Yeah, I mean, I never like to put steroid in when there is a tear.
Yeah.
Um, I definitely think it partly depends on the size of the tear. So if it's a very small tear that we're going to treat non-operatively, and we think therapy can help, but pain is limiting that, I can maybe make the argument. If it's a larger tear
Hmm.
that we think is going to have to be addressed with surgery, I definitely would not put any steroid in there.
Hmm.
It brings up a good point because usually, speaking from my own experience, a lot of the times when we're considering like a subacromial injection, we don't have an MRI or even like a diagnostic ultrasound to go
Hmm.
by. So, we would have had an X-ray, exams kind of consistent with it. There's no weakness. So, there might be times when we're putting some steroid in there when patients really do have small tears that we don't even know about.
Yeah. A lot of times, if they've had like trauma and I sense weakness on exam, I won't put an injection until we have some more advanced imaging.
Mm.
And I explain that to them. I say, look, if there's a tear there and I have the chance to make it worse, I don't think that's a good idea for you. And a lot of times it involves a lot of tempering of expectations because a lot of times we deal with patients who want to get better right away and it's just not possible and it's not a good idea. That's part of the problem is, some people be like, it's okay, I just want to feel better. And it's like, well, it's not okay. I don't want to be responsible. I don't like to, what first do no harm, I guess, so we're not supposed to harm patients and I don't want to cause people new problems. So, I've had that argument many, many times over the last 5 years, but, I try to stick to my guns there because I don't want to cause a new problem for a patient.
Yeah,
Yeah.
yeah, I completely agree. One other area in that localized region that is might not be torn but could be inflamed as well would be like the biceps tendon
Yeah.
itself. Sometimes you get inflammation around that.
Yeah.
So similar concept. Steroid, I guess, would probably still be my go-to if it was like tenosynovitis or
Hmm.
inflammation around the biceps tendon itself.
Sure. Sure.
Um, Sorry, we're going to add anything else to the
No.
biceps?
No.
Okay,
No.
so
I was just gonna say
then
maybe it always seems to be tender in that area, no matter what the shoulder problem is. It's like there's always
uh,
some component that the biceps tendon for some reason is painful. I don't know why that is, but you could always seem to elicit some significant tenderness there when people come with shoulder pain. So maybe it's the spasming of the muscle partially in relation to trying to stabilize the joint, but I always kind of I don't tend to think too much of it unless it's the only place that's tender because usually it's just always tender over that tendon for some reason. I don't know if that's what you see, but that's how I feel. Yeah.
yeah, I would agree. I mean, I'm only thinking biceps tendon if either mechanism of injury or aggravating factor or exam really just points to it.
Hmm.
Um, I think part of it could be like the leading fibers of the supraspinatus tendon are so close.
Right.
Everything's so closely together, kind of in that rotator interval
Hmm.
region that maybe just another reason. Um,
Yeah.
so now, what happens if we see a tear on the MRI or the ultrasound? What do you talk to your patients about? It's a tear, but there's still some fibers intact. Nothing's retracted, and we'll kind of go into what's different about that in a second. But how do you manage that?
Well, and have we done therapy and stuff already and that didn't get better?
Yeah,
Yeah.
yeah.
Yeah. If it's been a couple months and they've done therapy, I would still often offer the injection and see if that helps. And I think, like we talked about with the tennis elbow, if there's a tear, maybe an injection like a PRP type regenerative medicine injection may be more likely to help long term. But if they're still having a lot of pain and they've done significant therapy and it's been 2 to 3 months, I'd often offer one steroid injection to see if it can calm the pain level down. They can kind of progress the exercise program from there. Um, and yeah, I think I would do that first, and then typically, you know, if they can, again, we've talked about with PRP, the platelet-rich plasma, that can be often expensive, but if the patient can afford it, maybe one of those or one or two of those injections kind of into the area, the tendon tear may help to kind of regenerate the tendon a bit. Yeah, I don't know. What do you think? What do you do?
Yeah, no, I mean, I would agree. If it's not a large tear and it's not retracted, we'll still consider a possible injection. Yeah, I think part of it will depend on the location of the tear. So
Hmm.
if the tear is on the top side of the tendon, so meaning kind of in that subacromial space, subacromial type injection would work because the medicine will get there.
Hmm.
If the tear is on the undersurface of the tendon, so on the side that's closer to the bone,
Yeah.
usually in those cases, I'll offer a intra-articular uh,
Hmm.
steroid or intra-articular type injection
Yeah.
to allow the medicine to get to that area.
Yeah. Yeah,
So I will
that's
use that.
interesting. I kind of always offer the subacromial injection first just cuz it's much simpler to perform, and I don't need any ultrasound guidance or fluoroscopy guidance for it, but if that doesn't help, then I will oftentimes tend to offer one glenohumeral joint intra-articular injection, like you said, which usually requires us to use some kind of image guidance, either an ultrasound or the X-ray machine called a fluoroscopy or C-arm, and and you see kind of some patients who don't do well with the one injection, but they maybe do well with the second injection, and maybe that's some of the differentiation there is location of the tears,
Mm.
when you're providing those different procedures. So that's if the subacromial doesn't work, I'll often offer the glenohumeral injection, like you said, and then if that doesn't work, I typically won't inject any more steroid into the area there, and then might offer the regenerative medicine type injection.
Yeah, yeah. So I would agree with that. I don't think I would use anything, or haven't really recommended anything beyond PRP. I wouldn't necessarily think stem cell would be needed, although, if you have a large tear, you're not interested in surgery, I guess you could consider that as an option.
Hmm.
Uh, Studies are, there's small studies out there talking about that. But I oftentimes, especially in younger patients, will have them see a surgeon if there is a tear, especially more of like a moderate to large tear, because the rotator cuff is finicky. The tendon, which is where the tear occurs, is attached to a muscle. Right, tendon is attaches muscle to bone. So
Hmm.
when there is a tear, if the muscle isn't being used because it's not firing and things like that, you could get atrophy of the muscle. And when a muscle is not used, fat comes into the muscle, so it's like a fatty atrophy, and you can see the changes on an MRI or ultrasound, and that gives a poor prognostic indicator for any like surgical repair.
Right.
So I won't kind of just drag these things out if we're not improving significantly pretty quick with some of these things.
Yeah.
I'll at least have them talk with the surgeon.
Yeah.
I'll have them talk with a surgeon much sooner if there's any concern for that large tear,
Yeah. Definitely.
atrophy, or if the tendon is like retracted. So instead of where it should be touching the bone,
Hmm.
uh, if it's torn but it's still there, okay. But if it's torn and kind of pulled back, then some of our options are definitely limited.
Do you ever order MRIs like right away?
I do it. I do when I'm suspecting a rotator cuff tear.
Yeah. Yeah.
So a
Okay.
lot of like a slip and a fall, and now
Yeah.
they can't raise their arm up.
Right. Yeah.
I just go right to an MRI,
Yeah. Me too.
or if I have the capability right then and there, I'll do the ultrasound in the office.
Yeah. Okay. Me too.
Some shoulder elbow trained orthopedic surgeons are now even getting into the diagnostic ultrasound. So I know a couple that they'll plan surgery, do surgery based off the ultrasound findings. They don't even need an MRI. So
It's great.
yeah, saves money for the whole system, and it's, I think, quicker for the patient.
Yeah.
Uh, so the other thing with the shoulder injection, like into the joint itself, if there is labral issue or any arthritis of the shoulder joint, that would be where you would want the medicine to be placed as well.
Yeah. Yeah. Um, One other treatment that I've seen a little bit about for patients with really advanced arthritis is doing a suprascapular nerve ablation. So, um, we've talked about in some of the other podcasts in relation to low back pain that you can have a procedure done where basically we burn the little nerves that give you the pain sensation from the small joints there. And so every joint has nerves that carry the sensation of pain from the joint kind of up to your spinal cord and then into your brain, and then allows you to sense the pain. So for your shoulder joint, the main joint that provides that sensation is one called the suprascapular nerve. And the problem with destroying that nerve by burning it is that it also controls some of those rotator cuff muscles. But in cases where maybe you have really advanced arthritis, or maybe you already also have a chronic rotator cuff tear, a large rotator cuff tear, and you're not really using those muscles, I've seen a few case series where they've done this procedure and had some good results for pain relief, because I do see a good amount of patients with what's termed advanced glenohumeral joint arthritis who really, they can't move the shoulder much. If they move it, it hurts really bad, and so they just don't have much function with the arm. And so that's maybe one treatment that might be used a little more in the future, but I think some people are out there doing it. And before it's done, just like we talked about with the other nerve burning procedure, you should have a diagnostic injection around that nerve to make sure that the pain can be relieved by kind of numbing up that nerve. So I don't know if you've seen that done at all or thought about doing it. I've had a few patients who I've tried to refer to get it, but I don't know anyone in my area currently that's doing it. But I've read about it and thought about some patients it might be useful for.
Yeah, I've had a few patients. I haven't ended up doing the radio frequency. We've done the nerve block. Uh, yeah, it's kind of 50-50.
Yeah,
It wasn't overly impressive.
yeah,
So we opted not to do that.
yeah,
But yeah, I mean, it's definitely out there. Something to keep in mind
yeah,
for some of those refractory cases that either, they're maybe too old, they don't want to have surgery, or just they can't have surgery for whatever reason.
hmm,
Right. They would have to have a shoulder replacement at that point. But,
right,
so definitely something to keep in mind. Um, you
yeah,
know, this is a little off topic, but it was an interesting case that I saw recently, and the reason why we always inspect the area is this gentleman had really bad shoulder pain, like pain up in this area and even into the bicep a little bit, and it kind of resolved over the course of a couple of weeks, and he had noted a lot of weakness, and over the course of a few months his muscles kind of disappeared. There was a lot of atrophy, and nothing kind of brought it on. But by the time I saw him, he had no muscles. The rotator cuff muscles, you could see the scapula as if there was no muscles on him, almost like
hmm,
he was a skeleton.
yeah,
So that's obviously there's something more going on there. There's most likely like a neuromuscular issue,
right,
where you have to get an EMG and all these things. But it's interesting, just something to keep in mind. Always a reason why, with the shoulder, listening to the patient talk about it, inspecting, and kind of going through even like a self-directed physical examination can really get to the bottom of a lot of shoulder issues. So another reason why evaluating shoulder pain kind of lends nicely to telemedicine evaluations, because
yeah,
we can definitely um, uh, begin the process of diagnosis. Start with the physical medicine approach
yeah,
with the rotator cuff and scapula stabilization techniques, and if that doesn't get better, then we can kind of direct care from there.
yeah. I think one of the tough things about the scapula is it's on your back, so you can't see it unless you're looking in a mirror over your shoulder, or unless someone is telling you there's something wrong with it. And a lot of times you may not even notice something that's so severe like that if you have a lot of atrophy there. But someone like us takes a look at it, and right away it's very clear that there's something severe going on, or some problem there. So just
Yeah.
something that's easy to look at through a camera like this.
Yeah. I guess just before we wrap up, other things that we always should kind of keep in mind, is the pain coming from the neck, whether it be a pinched nerve high up in the neck or arthritis, that's kind of referring pain out to the shoulder. Uh, they oftentimes, will have some neck pain, but you don't have to have neck pain if you have a pinched nerve in the neck. Usually they will have a lot of like shoulder blade pain, but usually pain will also go down the arm with that. So there's ways to tease that out.
Yeah.
Some people might have heard of a condition called thoracic outlet syndrome. That's a whole other podcast. There may be a few, but that's something to kind of keep in mind as well.
So to kind of round that out, that is now the diagnosis that Markelle Fultz, this former Sixers player now on the Magic, that's the diagnosis that they decided on later after the scapular problem. They said actually it was thoracic outlet syndrome. And so then he was treated with that, mostly using an exercise-based approach. And the season just started now. He hadn't played in a long time, so apparently he had a pretty good first game, but I don't know if he's back to his previous form. But that was his final diagnosis, basically.
How about that?
Yeah,
that is a good full circle there.
Yeah, there you go.
I think the shoulder, just like every other topic, we could go into a lot more detail about each thing we kind of presented today. I think the take-home points, at least for myself, when evaluating patients like this or trying to educate patients, is a lot of muscle imbalance issues will cause dynamic impingement. It could lead to subacromial bursitis. It can lead to rotator cuff tendonitis or tendinosis and subsequent tears. So it really does come back to muscle balance, making sure you're strengthening all the surrounding structures to a joint, especially if you're using that joint repetitively, just to kind of keep everything in good balance.
Yeah, and I think just one last point on top of that, just to kind of note how complex this problem can be, is I remember someone once asking me kind of a question in medical school, is how many muscles connect to the scapula? And I'm not sure I remember the answer exactly, but I think it was something like 17 muscles. So, there's 17 muscles that connect to this bone that kind of just floats in space and really is very important for how your shoulder complex works. And if all those muscles aren't working appropriately together, you can get lots of issues. And so, shoulder problems are very common. They're more common in people who do overhead activities frequently or jobs where they're reaching over their heads. And there's good reason why we weren't made to do that. And there's lots of muscles there, and there's a lot of different things that can go wrong when you're doing something like that. So, just if you have any questions or need help with it, please reach out to us. We are happy to help.
Yeah, and if there's any other topics you want to hear discussed, either on our podcast or listen to videos on our YouTube page, feel free to reach out to us on our website. You could send us an email or on our Facebook page.
All right. Thanks so much.
Good work.